Welcome back, everyone. And now it is my privilege to welcome our next presenters, Dr. Rhianna Rogers and Dr. Eunice Wong. Dr. Rhianna Rogers is director at the Center to Advance Racial Equity Policy and a policy researcher at the RAND Corporation. Before RAND, she held administrative and teaching appointments in higher education and tribal government. Rogers is an expert on cultural and ethnic studies, intercultural competencies and diversity education, cultural mediation, and virtual exchange programming. She has successfully built and implemented diversity, equity, and inclusion programming for over a decade in higher education, private and public corporations, and NGOs. She created and ran the Buffalo Project, a longitudinal participatory action research project focused on using cultural data as the baseline for programmatic development and implementation. With numerous awards, Rogers grew the program, forming state and international partnerships, which led Rogers to be recognized as an international expert on equity-centered, community-based participatory action research by the United Nations Geneva Forum in 2020, 2021, and 2022. Dr. Eunice Wong is a senior behavioral scientist at the RAND Corporation. Her research broadly focuses on mental health disparities and mental health services in community and military settings. Much of her research has involved trauma-exposed populations and underserved communities. Dr. Wong earned her PhD in clinical psychology from the University of California, Santa Barbara. Please welcome Dr. Rogers and Dr. Wong.
Hello, everyone. It's a pleasure to be here, and thank you for that wonderful introduction. I'm going to be sharing our slide deck, but feel free to ask questions. We will try to address them in the chat. So let me begin. So our presentation today is, as you can see here, focused on making measurable impact in health equity. So we're going to be talking about a few case studies that come from the Center to Advance Racial Equity Policy, which is the center that I oversee at RAND, and some broader health equity research that my colleague Eunice and I are both going to discuss together. So first off, just thank you for being here, and we're going to get started to talk about a few things together. Well, first and foremost, RAND is really big about sharing research. We want to get our work out there, and we have a lot of repositories that are externally facing for free where we share information. So just FYI, if you want to do this, you can press Google and you can say racial equity research, RAND, and you're going to find repositories that focus on racial equity. You can do the same thing for health equity, and you could do the same thing for derivatives of that. So educational equity, military equity, and this will bring you across hundreds and hundreds of reports that we've done that are large scale, some things with the federal government, and small scale, some things with cities. And so what I'm showing you here as a graphic is a couple years ago, RAND, the overall organization, decided that they wanted to have a focus on racial equity and compiled a list of resources together that were of different ways in which RAND has impacted equity throughout time. For those of you who may not know, RAND's research is what actually overturned Don't Ask, Don't Tell, which was a major accomplishment, obviously, for society and LGBTQ+ communities. So one of the things I wanted to highlight in my part of the presentation, and then I'll pass to my colleague, is the broad spectrum of equity research that RAND really addresses and how we connect that equity research to impacting policy, just as that example I gave you about Don't Ask, Don't Tell. So my center really focuses not only on developing new projects and research approaches, but we also create new methodologies. So right now in press, we have 4 new methods, some of them dealing specifically with health equity. Actually, at the end of October, a colleague and mine, his name is Dennis, he's actually going to be presenting for Health Equity Affairs. It's one of the largest journals that we have in health equity, about a new equity measurement that we're putting in based on some research that we did inside of RAND and connecting writ large to NIH research that we're doing across landscapes. So that's one of the things that we want to do is we're not just about kind of writing reports, we're about making new methods so that we can drive the field and to actually make impact into the field. So I wanted to show this to you before I pass it off to my colleague, but When I was helping to set up the center for the last few years, I wanted to get an overall understanding of RAND's research throughout time. So RAND just celebrated 75 years, and we have been, and I'll pause for a second if you may not know what RAND is and its history. RAND actually was started as the research and development, that's what RAND stands for, branch of the Department of Defense. So we actually were part of the US federal government starting in the 1940s. We've since broken off and we have offices in the United States. We have 4 of them, and we have one in Australia. We have RAND International, which roughly sits in Belgium sometimes, and then we have RAND UK. But the reason this matters is I wanted to understand, what have we been doing since the inception of RAND? And as you can see on this chart, health equity is one of our biggest areas that we've been conducting research. It goes all the way back to 1954. Now, I wrote here that it stops in 2020, but it doesn't really. That's when this chart stops, is in 2020. But just to think about that, you can see that we have almost 700 funded projects that we have been doing as an organization in health equity since the 1950s. And these things have been really impactful. You know, I'll give you an example of just one of mine, and then I'm going to pass it to my colleagues. I'm currently working on some ways about thinking about health across underrepresented groups, directly connected to FEMA. So we're thinking about, how can we deal with mental health post natural disasters? And so what does that look like across landscapes? How does that look like as you disaggregate certain populations in society? So we're really excited about being here. And I want to pass it to my colleague, Eunice Wong, to get a little bit more into detail about research related to this.
Good afternoon, everyone. Thanks for joining us on a Friday. My name is Eunice Wong, as I was introduced earlier, and I'm actually trained as a clinical psychologist. So a lot of my work is focused on mental health, but a lot of our RAND colleagues do conduct research on cancer disparities and treatments. And so what I'm going to do during this portion of my time is to just give you some case studies of different types of research that has been conducted by RAND colleagues, either leading these studies or as co-investigators. And I tried to pick out examples along the different continuum of where we can intervene on equities, from ensuring that diverse voices are included in research, in clinical trial research, to the identification of disparities, to understanding what some of the factors might be underlying the causes of the disparities, to intervention research. So like Rhianna said, all of our publications are on our website, so you can access the full reports or articles there. We're just going to try to give you a high-level overview and some examples of the work that we've done. So this first study touches upon a discussion I was involved in yesterday in the roundtable around the lack of representation of diverse communities in clinical trials. And there was a lot of discussion yesterday about the barriers to participating in clinical trials in general for patients, but particularly for people in under-resourced communities. Everything from, it's a very complex process to try to get involved in clinical trials, and how providers and healthcare organizations often don't have the resources or the organizational capacity to help patients navigate and find clinical trials. And then, of course, one barrier that was mentioned were just the financial burden of participating in these clinical trials. Yesterday, Dr. Valle from UCLA gave an example of how even something like patients having to pay for parking at UCLA could serve as a barrier to participating in these clinical trials. So this study is trying to address those financial barriers to see if this might be a way and what the impact would be in terms of participation by more diverse populations. So in this study, they actually created a financial reimbursement program that covers quite a wide variety of expenses, everything from transportation and travel, lodging, meal expenses, parking. And if patients live further out, 50 miles or more, all of those costs can also be covered for a companion. And we talked a lot yesterday about some of the linguistic access barriers. And so you can see how maybe having a relative or caregiver or friend come with you to address some of those linguistic barriers could be a way to help boost enrollment in these clinical trials for diverse populations. They also, in this financial reimbursement program, our childcare expenses are reimbursable, and then reimbursements are made on a monthly basis, as opposed to sometimes when you complete trials, like a lot of the funds or reimbursements are made at the end. And if needed, they can even upfront the cost if patients can't pay for the cost and get reimbursed later. This is it's innovative because it's not done, but it's really just trying to meet the financial needs and the barriers to participation. And so this study is still in progress, and the real aim is to see if what types of patients wind up engaging in the program and what are the barriers and facilitators and the impact of providing this type of financial reimbursement. Next study. So this study, so we go from trying to enroll more diverse populations in research. And this study, so if you think about one other part of addressing inequities, is just the pure identification of the inequities. And so often patient cancer registry data sources are used as a surveillance. And because they can be slow and not as rapid case ascertainments are often used for more rapid assessments or surveillance. But the downside of the RCAs are sometimes that the data collected from there may not be as complete or as accurate. So what this study tried to do was see if it was feasible to implement a very simple, cost-effective way to boost the validity of race and ethnicity data that's collected through the RCA. So what this study did was it leveraged a large national study where they had self-reported data on race and ethnicity. And they focused in on California, about 4,000 California patients who were diagnosed with cancer between 2002 2005. And what they did was they compared the RCA data against the self-reported data, which they used as the gold standard, most accurate data. And they also compared the race and ethnicity data with the cancer registry data. And so what they tried to do was to see how much including Spanish surnames improve the accuracy of the data in the RCAs and in the cancer registry. And what they found was when they added the Spanish surnames, when you looked at the RCA data that was supplemented with that it increased the sensitivity of recorded Latino ethnicity from 37% to 83%. And they didn't lose much in terms of specificity. That only decreased from 98% to 95%. And then for the cancer registries, which tend to have more accurate data, the way that the data is collected there, that they still saw a slight increase in accuracy from 89% to 94% for recorded Latino ethnicity. And they also saw a boost in the accuracy of non-Latino whites, and that increased from 78% to 82%. So overall, I think that these findings show a simple, cost-effective way of really increasing the reliability and accuracy of data to really more accurately identify needs and disparities. And I think they also speak to the importance of standardizing the collection of race and ethnicity, which has been a topic of many other areas I'm sure you're all familiar with. Okay, next study. So this is a study that if you think about identifying disparities and then trying to understand the causes associated with the prevalence of these disparities. And so this study involved more of a traditional narrative review of the literature, and it was really honed in on trying to understand the documented disparities of non-Hispanic Black Americans showing higher incidence of colorectal cancer. And they honed in on two potential factors that may be contributing to that disparity, whether there were differences in colorectal screening, or whether there are differences in just the risk for developing colorectal cancer. And so they reviewed the literature and all the disparate multitudinous data sources, and then overall they found differences in screening, with Black Americans showing lower rates of screening than white Americans, but that based upon national surveillance data, that those differences seem to be narrowing. And what they really also a finding of sort of like the cause of these disparities, not only screening, but that these differences in the screening seem to be linked to socioeconomic differences, including health insurance. So when you looked at the studies where Black and white patients had comparable health insurance, you even found counterintuitive findings where actually screening was higher among Black versus white Americans. They didn't find as much, it was very mixed in terms of risk for colorectal cancer for various reasons in terms of the data sources that were there. But they also acknowledge that that is intertwined with screening, right? So it's possible if you're not detecting differences and risk for colorectal cancer, that could be due to screening. If one group is getting less screening, then that might mask actual differences in the prevalence or incidence of colorectal cancer. So that's an example of trying to understand disparities. Next. And then if we move into a case study of moving into intervention, this study was trying to look at the feasibility or the acceptability of having mobile mammography screenings either at churches or at locations close to churches. And it was a part of a larger study that was looking at the effectiveness of disseminating mammography information through 3 different mechanisms, through just providing churches with information, with mailings that had counseling material, and then through peer counselors. And so as a part of this study, there was something like 1,500 women from something like 40 churches in the Los Angeles area that were roughly divided between congregations that were predominantly African-American, Latino, and white. And using the data from the baseline data, there were questions about the acceptability of participating in screenings if there were mobile options available. And what they showed was that overall, there was a fair amount of openness to doing screenings through these mobile options. More than half of the participants said that they would be open to doing so. But what was more telling was the Spanish-speaking women were much more likely to endorse being willing to do the screening through mobile mammography. And then next were the English-speaking non-Latinos, and then the white English-speaking. So much so that it was 93% of the Spanish-speaking women were open to mobile mammography versus 61% of English-speaking non-Hispanics, which were primarily African-American women, and then 33% of white English-speaking participants were open. And certainly health insurance was found to be a big contributor to those who didn't have health insurance were much more likely to be open and receptive to mobile mammography. Okay, next. So this is the last study that I'm going to talk about. It's actually a study that I'm leading. The prior study that I just talked about was testing acceptability and preferences for different types of intervention. This is a study that I'm leading that's focused not on cancer, but on mental health. And it's an actual working in the community to actually deliver the intervention. So this is a study that is randomized, cluster trial of 14 parishes in the Diocese of San Bernardino. And it's a partnership between NAMI, the National Alliance for Mental Illness, and the Diocese of San Bernardino. I talked about it a little bit yesterday during the roundtable. And so it's the name of the project that all of the partners came up with is Proyecto Amen, which stands for Alma, Mente, Espíritu, and Nuestra Comunidad, which is heart, mind, spirit, and our community. And so this is a multi-component, multi-level intervention where we're building partnerships between NAMI, a grassroots nonprofit organization that provides a lot of mental health education and advocacy, with a diocese, mostly Spanish-speaking parishes within the diocese. And the components involve at the individual level, flooding the parishes with basic mental health information. And there's a component where we organizationally provide, NAMI has these Fate Net programs targeting the leaders. And then we're hoping that by targeting at a congregational level and the leaders, that this will promote organizational change within the parishes to reduce stigma and then increase access to treatment. So we're right in the middle of this study, finishing up the intervention phase and moving on to the follow-up survey assessment. So to be determined in the future. But hopefully that gave you a good sense of the breadth of studies that we do at RAND. I encourage you to, like Rhianna had suggested, Google RAND Health Equity, and you'll come up with a whole greater list of different kinds of studies that we've conducted at RAND. Back to you, Rhianna.
Thank you, Eunice. And I kind of wanted just to highlight a couple of things that Eunice mentioned as we transition to thinking about what do we do with this information. As I mentioned to you before, the center is really big about making an impact. And so we have all of these studies, but we want to thematically look at how do we actually take what we're finding in data and connect that to a couple of prongs. One prong is the development of new methods. Another prong in the center is actually through communication, which we call democratic dialogue or deliberative conversation. And another prong that we try to connect through is through fellowships, actually bringing people into the community, into the center to learn about this information and to spread it back. And so we tend to call that in equity-centered design, responsive design. What we're ultimately trying to do is we're trying to connect the researchers, the people who are collecting data, with the community stakeholders on the ground so that they can use this information together in ways that can help community and society move forward, whether that be through the development of policies or procedures, whether that be through understanding people's lived experiences for this, in this example, cancer, right? So what is the disaggregated lived experience of people from different communities, different parts of, let's say, Los Angeles, different parts of, the educational process? How do those cultural variables that we're collecting in all of these studies break down to real people so that we can go back to those real people and say, here's some information for you that you can take when you go see your doctor, when you go into a medical situation, when you're asking your community for support, that you actually have that information to be able to take it forward. And what we're doing in the center by doing that is we're trying to get people in different contexts around equity, thinking about data for them as an asset that can help them move forward with understanding not only the way that this research can work for them, but how it can also highlight the distinct cultures, the motivations, and the perspectives of all those that are involved. I was helping to run, and I'll show you on another slide, a couple of projects that I'll tell you in the center that kind of highlight this. We just had, and we're going to have another one very soon, an Noguchi Fellow. So my former colleague on the right, Martin Noguchi, was a advocate inside of RAND. He did a lot of equity research before he passed away, but his family has created an initiative to carry on his legacy. And we just had the first ever Noguchi Fellow, Patrick Hendricks, who is an administrator overseeing 10 hospitals in the Chicago region. And so one of the reasons I wanted to bring Patrick together was to think about health equity writ large. And so he looked at everything these 10 hospitals did and wanted to think about, as I mentioned, disaggregated data from his own interest, was how are these 10 hospitals helping the Black male experience in Chicago? And so we started working together on getting to his research question. And what was really interesting is it expanded over time because he actually learned things. So I'll tell you what his study was. It went on for 3 months. He pulled together focus groups of individuals in Chicago from different sectors of Chicago to hear about their experience going to hospitals. This involved individuals from all walks of life. It involved individuals that did have cancer, that did not have cancer. It involved individuals that were just, what is their experience? What was interesting is we wanted to make this a comparison. So Patrick happened to live in DC as well as Memphis. And so we actually made a 3-city study where he looked at what is the lived experience of Black males in these 3 contexts in hospitals and how are their experiences differing. Well, what was really interesting is that his study found that there were a lot of things in common. Number one, which was a sad statistic he found out, was that the average Black male had been either incarcerated or shot between the ages of 18 to 35 in all 3 of the contexts. That was the highest propensity was to have that happen, which means that you're most likely going to be in a hospital at some point. What also happened that he found was an interesting statistic is that if you had been hospitalized for being shot, you would most likely have 2 additional times of being hospitalized, which means there's a break in the system that he found. What was interesting about the overall study that Patrick did was although he had a particular interest in coming through this vantage point of Black male experiences, he was able to do a presentation at RAND that talked about some general macro level ways that we could become better researchers. And a couple of things that he said, which I'll share with you here, is don't make assumptions. He said one of the biggest things that he learned is that even the understanding the phrase Black, African American, it's not a monolith. He and I had this conversation a lot where I said the phrase Black in America could be Caribbean Blacks, could be African American, could be Black, could be Black immigrants, could be Canadian Black, could be a variety of iterations of what that word means in that context. And that it's very important that you dig deep into finding out who those people are. So I'll translate that even into the cancer research area of what RAND has been doing. We've been disaggregating the ways that we think about cancer. It's not a monolith of a field. There are many different idiosyncrasies, whether it's socioeconomic, racial, ethnicity, region of where you live, education, access to healthcare, access to insurance. All of these factors need to be disaggregated to get a true understanding of how cancer is impacting individuals, communities, regions, cities, states, and you just keep getting bigger from there. The other example I wanted to highlight is, as I mentioned in the center, we actually create new methods. So here's a method that has been adopted a lot across a lot of projects. And I would encourage you when you're thinking about conducting cancer research that you might adopt this model. So let me explain why this is helpful. And apologies, I'm sick, so it's taking a little bit for me to talk. So basically in this model, you're seeing 3 phases. So here's the challenge that I would give to you. In the first phase of work, this is a constant problem that I see. There was a study that was done at St. Catherine's University a few years ago in 2015 and 2019 that talked about publications across the United States. And in this research, and I'll post it in the chat box in a second after I stop sharing, but in this research, they found that 70% of all publications in the US and Canada were written by white women, all other variables left aside. So that means if you are LGBTQ+, if you had visible disability, if you're a white male, if you're Black, African American, if you're Latino, Latina, you fit into this 30% only writing area out of all the publications that were coming out in the US and Canada. And I'm not just mentioning academic, I'm saying all publications. So here's the reason why that matters. Imagine if you're conducting research on cancer research and you don't know that inequity that exists in publications. You might prioritize a perspective of the dominant 70% and not realize it. So what we've done in this environmental scan, this new way of thinking about including research that's not typically published, let's say in mainstream settings, is we've opened up space for gray literature. And so that's what we say in phase one. It's not just looking at the academic literature, which may be leaning towards a particular vantage point and entry point. We want to look at gray literature. We want to look at blog posts. We want to look at hospital newsletters. We want to look at community announcements. We want to hear what people's recordings are, like this one that we're creating right now. We want to look at all of that in context in order to give us a holistic entry point, in this case, into cancer research, so that we're not just looking at the variables that maybe the publishing houses like to publish, which could not be the whole story. The other thing that you do after you move through that phase one is you get to phase two. Phase two is, okay, we've tried to pull from the academic and gray literature spaces, but are there any additional themes, gaps, or practices that we don't know about? And so in a lot of projects, including the one I mentioned about Patrick, that's why he did those focus groups. That's why he went out to speak to the community. That's why he sent emails across those 3 cities, because he didn't want to just say, I think I found everything. Let me ask some of the people that are writing those blogs, that are doing those interviews, that are doing their conferences, and see if they know more than I know, so that during the second phase, I can either identify additional gaps, find more themes that maybe I couldn't find on my own, and then I can pull these all together to develop more inclusive practices. Now, the very bottom of this approach really requires us to disseminate our findings. And so this is a really important thing that I think about a lot in my work, is not everybody wants to read a report. Not everybody is interested in a really long book to read. Some people want something short and quick. Some people want to come to a seminar. Some people want to watch a TikTok video. Some people want to do lots of things. And so in my center, I'm also about producing products that are non-traditional, that will bring in different people in order to get them to be aware of the things that could be impacting their lives. And so this is something I would encourage all of you thinking in the cancer research space. How are you disseminating your work? Are you disseminating in diverse ways? I think this is a great example of doing one of those such things right now. But are there other opportunities? Are you using social media? Are you gamifying things? Are you creating different opportunities for people to connect with, understand the importance of cancer research, understand how they can see themselves and their family in those spaces through the ways that you're disseminating information? Now, I wanted to give you an example of this kind of fully played out, which is another project. This was a colleague of mine. She's now full-time at RAND, but when she started this project, Dr. Mashida Breer was a medical professional at the University of Michigan. And so she went through this model. Actually, she was one of the first people to help me create that model when I first came to RAND. And what we wanted to do is we wanted to apply this specifically to University of Michigan in 3 underprivileged locations. One, we had Detroit, one was University of Michigan itself, and one was Flint, Michigan. So we looked at these as 3 separate contexts, and we walked through what I just showed you as that circular wheel. Now, here's something that was really fascinating from our focus groups and study groups. A lot of the literature talks about health disparities. Well, here's something that we could tell you. A lot of the people in the community said, we don't want to hear that phrase anymore. We don't want to center the word despair. We're not interested in that. Please stop using that when you come to us, because we already know that we're in an economically depressed place. We don't want to hear something on top of it that is something worse for us to feel about. So if you read this report, you'll see that we talk about this, but we'll remove some of the words that the community said. A lot of those people that you see written as the authors of this, these are all the partners. So if you look, Dr. Breer is at the very end. She prioritized all of the community as writers first. The other thing that was super interesting about this study that we found was we have a common tendency in research to talk about creating pipelines to education, pipelines to the future. And what we heard from this study was, from the community, they said, we don't want to hear the word pipeline anymore. It reminds me of pipeline to prison. If you want to create something, create a new word for us. And so if you notice, the name of this project completely changed to Pathways, because that was our community coming together that we were working with and saying, we want to find positive words that will help us to look beyond some of the negative things that we're encountering in our community, but that we can draw together through hope and empowerment on new words that can help drive us into a place that are going to make us feel better about ourselves, work towards a common goal. So I know we covered a lot of information here, and I just want to say thank you. I'm going to actually highlight another quote that I mentioned from that research, but I always like to kind of end on this overarching quote that I made even before I came to RAND. So it was a few months before. Whenever I'm applying a racial equity lens or equity lens, it means that we're not just interested in closing the gap between racialized groups, but that we're striving to equalize the playing field through inclusive research and data-driven policy reform. Advancing racial equity moves us beyond just focusing on disparities and refocuses us on developing inclusive and equitable solutions. Systems that are failing marginalized populations are failing all of us. Research shows that deeply racialized systems depress life outcomes and are costly. Thus, advancing the work that we're doing in racial equity and equity writ large enables us to increase our collective success and help improve society overall. So again, I wanted to say thank you. I'm going to stop sharing for a second, see if anybody has any questions, and I'm going to post that additional link that I was mentioning in the chat box.
Thank you so much, Dr. Rogers and Dr. Wong, for the great work that's going on in RAND. And thank you for bringing up the idea that language matters, right? Using the correct language, and that's why it's so important to involve community and people with lived experience, so that they can tell you about that language that they prefer to hear and to be used. Now, me working in a health system and, being a health equity director, this is something I'm constantly getting asked, and it's not an easy question. So I'm going to pose it to you all. What are some of the key indicators or metrics that you think researchers and practitioners can use to measure the impact of their work on advancing health equity?
Yeah, that's a really big question. I think it really depends too on disaggregating the fields. So, I would say overall, we came up with some factors. So I'll give you an example of an educational entry point, and then we can maybe talk about scientific entry point. So an educational entry point means open access to having education. We don't see representation of doctors and nurses the way that we should, for the way that our society currently is right now. The ratio of doctors to nurses is still very much leaning towards white male. And we already know from a variety of studies that we've conducted inside of RAND and out that lack of cultural competency inside of educational experiences, like it wasn't a requirement for you to learn cultural competencies to become an MD in most programs. And so when you don't have quote unquote good bedside manner, one of those problems, those can be perpetuated. So even there, I would say it depends on where you kind of start. It might not start already in the field. It could start, how are you preparing the people to get into the field? And I don't think we've done a good job of that yet. Eunice?
Yeah, that is a complex question. I mean, I think there are sort of like the standard metrics that are available in research, and then it's moving toward these equity types of progress indicators. But I think what we've all been talking about, it's really, if we're thinking about equity, it really should be the voices of the community that are giving input into what they think is equitable, like progress towards equity.
Thank you. And that brings me to my next question. How can researchers ensure that their studies are designed and conducted in a way that addresses those unique needs and perspectives of the communities that they aim to benefit in the context here of health equity research?
Yeah, I'll start. I think one of the biggest things is making sure that you're vetting your data by not just making assumptions of what the data. I mean, the biggest thing I always have, and I say this to folks, and I'll give you an example. I was working on a really large project, and my colleagues at RAND were saying, like, we really want to dig down to X population. And I said, well, you're using this national data source. And I said, have you actually checked to see who's represented? And in this case, they were looking for Indigenous populations. And it turns out there were 6 Indigenous people in the entire national sample. And those 6 people were all from the Northeast. And I was like, you can't say something about the entire United States landscape of Indigenous peoples when you have 6 people representing just the Northeastern United States. So I think it's really important that you're asking these really important questions early on. You're saying, like, who does the data represent? And have I dug down to determine if that data is actually representing the people that I'm hoping that it does? If it doesn't, am I going to those populations to fill in those themes and gaps? And that's the thing that we have to take that extra time to do, because otherwise, I was actually working with a new RAND graduate student who just came in, and he was like, oh, I want to really conduct this study about, cancer research. And, sometimes I'm talking to people who have to do like certain studies that connect with your hair. And I was like, have you done any research on hair studies? Do you know any of the field? Because there are people, like I'm showing you, I have locks. It doesn't work on people who have locks, some of these types of things. And it would require you to shave your head to do certain things. And I said, some of those people, and I said, think if you're Rastafarian, which we have representation in this country, that's religious. Cutting that off actually has different connotations than it just means for wearing a hairstyle. And so I was challenging the student to think this way, because when they entered in through a lens of just the scientific hypothesis of creating something with electrodes that could easily fit to someone's head, not thinking about the various factors about what does that actually mean to different people.
Yeah, and I think added to that, and I think we've talked about, and throughout the conference, is involving community members at every step of the research process. And so a good example, Community Partners in Care, this was led by Ken Wells, who's at UCLA, but also at RAND. And his was the first randomized controlled trial of testing community partnered engagement as a method versus sort of like just technical assistance. And it was through their partnerships with a community where it was focused on depression, but they really said that measuring risk for homelessness was an important outcome, which now it makes sense, but this was, I don't know, 10 years ago, right? Like people didn't make that connection as closely back then. When you were thinking about depression, you're thinking about symptoms and functioning and all of that. And so that's a good example of that being included because of community input. And then in my current project, where it's bringing two very important community resources in the community, just having the partnerships having constant dialogue. It's not the outcome measures. I mean, they have input into all of our measures and surveys and things like that. But I think what's really valuable for them is through this process, hearing what fits for one community and the other, and how do you meld those two cultures together. And that's kind of the responsive design, so that we're actually adapting a lot of the intervention activities in the middle, right? Which is very non-standard in a RCT. It's like you stick to your intervention and you are fidelity, and we just allow it to continually adapt with input from the community.
Thank you, Dr. Wong. And that being said, then what advice do you have, or how can researchers then effectively engage community stakeholders in research so that they do that CBPR, that CPPR?
Yeah, I think there's a couple ways that I would say that, and I'm going to use an example. So I know that Eunice earlier mentioned about representation in clinical trials. I think that's something that's really important. I'm going to give you an example of when I used to live in Buffalo, New York. There was, so I am an anthropologist through and through. I like to put myself in different environments. And one of the environments I put myself in was to have my doctor be in the immigrant community neighborhood. It was a segregated community. I did not go to the wealthy side of town. I went into different sides of town. I had doctors in different sides of town because I wanted to know about the holistic experience of people. One of the best things that I saw happen by going to that doctor is in that waiting room, where there were people that were financial advisors who were sitting around breaking down financial advice, where there were people that were talking about, do you need food at home? We can set you up with a food care center. But here's the problem. Anytime I went to the doctor in any of those other environments, those same supports weren't there. It was only in the most extreme community environment that I saw the healthy supports that needed to be there were there. Even in Los Angeles right now, being here for the last 2 years, I see that similar thing going on, where it's the most extreme environments that are receiving these resources, and it's making the assumptions that the other environments that people are going to the doctor do not need them. And so that also goes along with clinical trials. I have very rarely heard during clinical trials that you have any of these external supports that I'm mentioning to you that would draw in individuals to want to take part in these projects, because that's the stuff they need. For example, if you're doing a clinical trial, Eunice brought up about parking, childcare. If I'm working 2, 3, 4 jobs, I can't sit in a doctor's office for 2-3 hours without knowing that there's going to be child support on site. I might not be able to afford it on my own. Even if you're representing a population, I might be afraid. What happens if you are an undocumented immigrant? What happens if you speak English as your second or third language? What if you have an invisible disability that's been undiagnosed? There's so many factors that we're not really thinking about that I think we need to think about moving forward. That's the only way that we're really going to create the level of inclusion that we need. The other thing too is that there has to be better translation of why cancer screening and just screenings in general and medical providers is important. We're fighting against trends in populations where they know that medical providers didn't always support them. Like, I'm going to tell you, when I first moved I'm in Inglewood right now. There was a newspaper that was put on my door when I first moved here, and it said, COVID is related to the Tuskegee Airmen crisis, and it was going around the whole neighborhood. This was specifically targeting African-American people to scare them about COVID by connecting back to a time previously in US history when the US was working against populations.
Mm-hmm.
I have seen that same rhetoric happen in other populations. So we have to be honest about that too. How do you address, and if you're ignoring that rhetoric, that's the problem. You have to let people know you're aware that that exists, but we're not doing this and we're showing you why. But you have to really give voice to the history of why people might distrust. I could keep going because this matters to me, but I'll share time with Eunice. Go ahead.
I think to add to that, I think what's really important is trying to align what is important to the community. I think what, as a researcher, the things that you are researching, that it aligns with what they feel passionate about and what they feel important, in finding that commonality. And it takes time, because I think a lot of communities aren't used to research. So it's a lot of patience, a lot of co-learning, and a lot of flexibility. I think from people, researchers who are trained in the scientific, rigorous methods, you have to be flexible. You have to meet people where they're at. So an example is, in my current study, we had the typical community advisory board with all the different faith-based and NAMI, and we're going to meet regular intervals. Well, a lot of the church leaders couldn't always meet that regularly all together. It was a big burden. So then we would go out to them and just have, like, when they couldn't do that, then we'd individually meet with them and we'd go with them to get their feedback. So I think sometimes the structures aren't conducive to their organizational flow, and so we have to adapt to them.
That's a great point. Bringing the research to where people are, right, as opposed to expecting them to come to us and academic centers. So a question came in asking, when you evaluate research literature, do you look for genetic differences and variations within similar, in quotation marks, appearing ethnic groups? For example, Indian versus Bangladeshi, Somali versus Nigerian, Cuban versus Brazilian, etc.
Yeah, I mean, this is a huge discussion about race versus ethnicity that I think we've been engaged in for hundreds and hundreds of years. If you're unfamiliar with this, I was involved in the American Anthropological Association's Race Are We So Different? I'm going to put it into the chat box, which addresses some of these concepts. But I just want to highlight the struggle that we have in this space is the constant mixing of something that is genetic markers and something that is a social construct. And I think it's very difficult when US culture has blended these things together. I'm going to use myself as an example. I am genetically 12 races. Genetically 12 ethnicities. There's nothing in me that's over 50%. I speak multiple languages. My second language is German and my third is Spanish. But if you look at me based on historical context of the United States, and we have a concept that goes back to Reconstruction called the one-drop rule, which meant if you were 1% African descent, it negated everything else. We have a social construct that perceives me to be African American only. Now, what's interesting, I lived in Mexico for a long period of time. They have a completely different social construct. So I'm going to give you this as an example. There is this thing called the Castas paintings. These are cast paintings, Castas paintings. So the Castas paintings created terms like criollo and mestizo and all of these words. They come from somewhere. There's a painting series. You should look it up online. It's very cool. But basically, this painting said, when the Spanish and the Portuguese came over, they only brought men. So they were marrying in from the very beginning to indigenous populations and African populations. And so the Spanish crown and the Portuguese crown needed to find a way in order to say that they were Spanish. And so they created a series of paintings because people were illiterate. So here's the reason why that's so fascinating. When I go to Mexico and I'm there, we just talked about last names, 2 last names. This actually comes from the Costas paintings. It's because your family origins matter more than your skin tone. The very first president of Mexico was multiracial. He was probably the same skin tone as me. The thing is that we don't understand that. So think about why now, if any of you have 2 last names, my partner has 2 last names, it's the reason why. It's because of that connection. Now, let me tell you why that matters. If you deconstruct the social construct of the US and Mexico, and you pull that away and you just take genetics, we would have a universal baseline of measurement for people. But because of the social layering that's on top of both of these cultures, this is where we struggle with being able to help people. And what I would say to all of you budding scientists, all of you who are scientists, knowing that context of where you are performing your research and science, it's a critical layer of making sure that you're not building bias into what you do.
Thank you. And, I did see a LACMA exhibit with those Castas paintings a couple years back. So who knows if it comes back to those LA folks who it'll come back to LACMA. And like you said, it's just fascinating, how many different caste systems there were, right? And you don't typically think of Mexico and caste systems, but exactly, and I think there's also the point of the importance of disaggregating data, right? Because I know as a Latina, I kind of get, I get annoyed that I have to answer the race and the ethnicity because I'm like, I just told you I'm Latina, but then I have to pick a race and it's just like, well, what am I? Am I white? I have indigenous background, so which one do you select? So it can be confusing, but also the importance of collecting that country of origin, right? So that we can desegregate some of those areas because they do kind of hide some of those inequities that we see, right? In Asian populations and Latino, in all populations. So yeah, we have our work cut out for us when it comes to data. But I'm going to ask you another question. And, and Dr. Rogers, you brought up your third step was about dissemination and how we have to go beyond peer-reviewed journal articles and books. So can you provide insights into how research findings can be translated into actionable policies and practices, right, that address health disparities and promote equitable healthcare access and outcomes? And I think I'm learning that because I came from 15 years in academia and I was doing the research and you're in a little bubble in your vacuum. And now I'm in the healthcare system working for a managed care plan and it's completely different. And so, how can we translate that into those actionable policies and practices?
Yeah, I think there's a couple things. People have to de-silo. That's number one. I think one of the problems is that we're used to communicating in the same circles. And so we go to those comfortable circles to communicate our information. Even with publications, there can be people, and I see this often, that will publish in the same journal all the time. I think in my career, I've published in the same place like twice, like once. And it's because I've gone intentionally out of my way to try to diversify where I'm putting information so that I can speak across areas. What I think it's really requiring us, the modern day researcher, is to be more of an interdisciplinarian. You have to be able to understand that representation of different disciplines can help focus on whatever specific topic. So in this case, we're talking about cancer. If I were only to look at the scientific entry point, I just gave you a whole mini history lesson, I would have completely deleted that. Right. And it would have been, and we've seen what's happened as a result of that in the US and in Mexico, where you don't talk about those historical origins and you get things like, and I don't want to be crass about this, but human zoos, which we used to have in the United States. So these are the problems of when you're looking at something through a very just kind of finite lens, is you don't get the interestingness and intricacies of the other things that are building around that, the human elements, that holistic view. I think we have to challenge ourselves to do that more, put ourselves into contexts that are different than ours, ask people that are outside of our disciplines questions, so that we can have a better understanding. Ask people that don't have degrees. Ask people that are just walking down the street, what do you think of healthcare? And use all of that at the same level of empowering knowledge. don't prioritize just one type of entry point of knowledge over another, because I'll tell you, many often times in my own work, it's the people on the street who have helped me more with guiding innovations in my research than it ever has been the people that are in academia, to be honest. Eunice?
Yeah, that is a tough nut to crack. I would say at RAND, given that is, you know, one of our top priorities, getting our research into policymakers' hands. So, you know, we have a whole team that their sole focus is getting our research into the hands of policymakers and building those relationships. But I think if you don't have that kind of support, even thinking about like the kinds of materials that go to the policymakers are not the same materials that go into our scientific publications. So I think that piece of dissemination, like short, quick, you know, things that they can digest is so important. And, you know, finding, I think the multi-sector partnerships too, like being able to partner with other organizations so you can have more of a voice at the policy level, because you probably can't do it all on your own. I'm sure you have lots of other things you're doing.
Yeah. Absolutely. And you're so right about having to make it more digestible and, you know, in short spurts, especially for policymakers. And I've also learned that you have to put on, you know, in academia, you don't often put on that financial hat, right? It's the greater good, and we're doing it because it's going to improve health outcomes. And oftentimes in these health systems and policies, you have to put on that financial hat and do cost benefit analysis. And why is it worth that investment? What is that ROI? And it's not just for us, our altruistic beliefs that because it'll make things better for people, because we want to create healthier communities. So thank you for pointing that out, you know. And then I think also, you know, perhaps we can add that one of the things that we don't see often, and we're seeing that happen a little bit more, is getting that information back to those who participated in that study. Right? Oftentimes participants say, great, I participated, I never heard anything again. And making sure we disseminate those findings, keep them in the loop so that they can see what came out of their participation, how important it was. I know, because I think, you know, Dr. Wong, I told you this in our panel yesterday, that's my background in my dissertation in diversity in clinical trials. And that's something I heard over and over again. We want to know what happened. Don't just use us as guinea pigs and then forget about us. So I really like that idea. And I know we were like creating newsletters, actually involving some of our patients in the dissemination and in the creation of how we were going to disseminate those findings. In addition to Dr. Rogers, and I think you also pointed out that, you know, giving them credit in those publications. I know for us in academia, it's publish or perish, but it also benefits, you know, some of our community members and our partners, because maybe if they run small community-based organizations, this is an opportunity for them to get a grant, you know, to have, you know, some sort of, you know, background in partnership that can help them leverage it for capacity building.
Yeah. 100%. 100%. I think that's the other thing that I didn't mention about building partnerships is giving back. Like there's so much volunteer, like people who do community-based, like there's so much volunteer time that has nothing to do with the study at all, but it's building their capacity in other areas that is really essential to those partnerships.
Yeah, it's we do ask a lot of our patients.
Well, I think the big thing that I would say is I always stress, if you really want to be equitable, you don't focus on outcomes first. You focus on people first. Because if you focus on outcomes, you become inflexible to the changing nature of people. People, if you're having a 3 to 5 year study and you're making an assumption that something isn't going to happen in 3 to 5 years, all of us on this call know that things happen in 3 to 5 years of our lives. All of us. And so we have to be cognizant that our lived experience as those who are researchers are reflective of those people that we are working alongside or with. They have the same wants, needs, and desires as we do. In some cases, they may have even more wants, needs, and desires if they're coming from an underrepresented background. And so I always talk about this idea of not only empathy, but humility in research, because you have to make sure these two factors are incorporated in, or you could bulldoze a population because you think you're helping them, but it's this very You know, I talk about maternalistic, paternalistic a lot. It's this very idea that we know better, which honestly, we've seen how that plays out in other research. It doesn't usually play out well.
Yeah. Thank you for that point. Yeah, humility, yeah, I think is one of those top characteristics that we need to bring with us when we're doing research, because you're absolutely right. We can't come at this by saying we're the experts. It's really the people we're working with that are the experts, and just leveraging each other's strengths and resources. We just happen to have maybe more resources at hand being in academia. So I do want to thank both of you, Dr. Rogers and Dr. Wong, for joining us today. We are at the end of our session. Thank you for showing us how we can measure health equity, some examples, and thank you for sharing the links and the articles, because I know oftentimes when I come to these events, I'm like screenshots and trying to find it in Google later. So thank you for sharing those with us so that we can share it with all the attendees. That is actually very helpful. I was actually saving them and bookmarking them in my Google as you were speaking, because I'm going to go back and read them. So I do appreciate all of that for you all sharing, and we look forward to more of the work that's going to come out of RAND, and more of the work that both of you have done, and can't wait to see more about that Amen study. And I love how you use the word Amen. What was it? Alma, mente, espíritu y nuestra comunidad. I love that. See, and I remembered it, so it works. The acronym works. So I want to thank everyone for being part of Cancer Support Community Los Angeles Health Equity Summit today, elevating patient narrative in cancer care. Again, we want to thank our sponsors, St. John's Health Foundation, Grow at Annenberg, Pacern Family Foundation, Walgreens, UCLA, Cedars-Sinai, Insight Pharmaceuticals, Tower Cancer Research Foundation, and Anthem Blue Cross. I do want to remind you all that if you're in the LA area, we invite you to attend our upcoming open house on October 19th from 4 p.m. to 6:30 p.m. You can see the Cancer Support Community Los Angeles space firsthand while enjoying light snacks and drinks. You can email Kelly at khagen, that's KHAGEN, at cancersupportla.org to RSVP. And we look forward to seeing you next year. Have a great evening, everyone.